So welcome everyone, welcome on Tuesday morning, and for joining me on this chat about how to solve a problem like furcation. So sounds like I'm going to burst into song from Sound of Music, but I'll spare you the embarrassment of listening to me sing. So just a little bit about myself before we start talking about furcations. I studied at the University of Sheffield, had a great time there. Love Sheffield, moved back to London close to family and had my 3-year specialty training in periodontics at the Eastman, and now I work in practice, in private practice, and also teach at the Eastman Dental Institute, the CPD department, regularly on the periodontal courses and the aesthetic courses. So it's been a strange few months. And I've been doing lots of other hobbies, like baking sourdough bread. So this is my beautiful starter. It's a great thing to do. And I hope I can continue it when I'm busy back at work. So I have been going back in the last couple of weeks, but as things get busier, I'm sure I'll spend less time baking bread. But always look to silver linings during lockdown. The other thing which I've been getting up to is going on this Facebook group, which is fantastic. You also get to see what fantastic gardens other dentists have, and you get lots of inspiration. So oral, flora and garden pathology. As a periodontist, it's extra stereotypical that as a gum gardener, I'm enjoying my gardening, but this is a great little Facebook page I've been enjoying as well. So this week I've been fit testing, and yeah, this little meme, something my wife created because that's what she felt I looked like, and it's pretty scary for patients. I have to be honest. Wearing something as scary and intimidating as that, I mean, we can be scary enough of the times for our patients, and we use our communication skills to try and keep patients at ease. But when we are dressed like this, it is quite challenging. So I'm sure it varies practice to practice, but what I've been finding very useful is actually these consultations, these chats on Zoom or other video platforms, where you can talk to your patient, they can see your face, you can interact with them, treatment plan with them, and then when you see them, they're prepared to know that you will look something like Hannibal. Okay, so onto the topic of onto the topic which you all have come to hear me talk about, furcations. I'm going to start with really basic glossary of terms. So furcation is the anatomic area of multi-rooted teeth where the roots diverge. A furcation invasion is a pathologic resorption of the bone within a furcation. So these are some classical studies. Hirschfeld and Wasserman looking at over 600 patients, 1,400 teeth, and percentage of teeth lost with furcation involvements of 31% over 15 to 53 years. What this shows as an overall broad picture is that depending on whether the patient is well maintained, not well maintained, we can keep teeth for a long time, and we can keep compromised teeth for a long time. So before we pick up our forceps and we see a furcation involved tooth, we must think, how long would this survive if we didn't remove the tooth? So this is always something to bear in mind, and hopefully by the end of the presentation, we'll be thinking twice before we pick up our forceps, and we will be maintaining teeth for longer. So if we look at the pathogenesis of furcation involvement, lots of different causes. You can have endodontic pathology, lots of connections in the furcation area where an abscess can develop and bone loss can develop. Plaque-related periodontal pathology, such as periodontal disease, occlusal trauma can contribute to the bone loss, and a combination of all three of the factors above. So I'd say those are the four main pathogenesis of a furcation-involved lesion. And please remember, if you have any questions as we go through, please feel free to put them in the question and answer box, and I'll go through them at the end. So local factors, things that can influence furcation involvement. So you have the root morphology, the divergence, convergence of the furcation entrance, enamel pearls. Don't see it so often, but you can get these little enamel pearl projections on the side of the furcation, on the side of the furcation entrance. Cervical and enamel projections. Now these are extremely common, and I'll show you these. And you probably, now I've shown you them, when you look in practice and you have an assessment, you will find them. These are something always to look out for, and I'll discuss them with you in a moment. Bifurcation ridges, they're extremely common, especially on lower molar teeth, accessory canals, and restoration. So all these local anatomical factors can influence the extent of furcation lesion. So if we look at root morphology, we need to look at the degree of separation. We need to look at the divergence of the roots. Okay. If we're able to maintain the tooth, so are we able to clean between the furcation? Now there's fornix. The fornix is like the internal dome structure. So if you look at it underneath here in the furcated area, there is a dome structure, so which is higher up than the furcation entrance. So when you're cleaning between the furcation, you also need to clean superiorly, coronally rather, to clean in the fornix, so the dome-shaped structure underneath the molar tooth. Also, we need to look at root trunk. A long root trunk may be less susceptible to furcation involvements. A shorter root trunk more susceptible. If you're able to clean between, if there is a furcation involvement when there's a long root trunk, the patient might not be able to clean the area. So lots of different nuances that we need to look at when we are treating the teeth, either through non-surgical means or surgical means, or when we're assessing the prognosis of the teeth. All these different root morphology factors we need to take into account. So when you're looking at root morphology, 81% of furcation entrances are less than 1 millimeter in width. And you've got all these concavities. If we look on a lower first molar, the mesial root is a figure of A shape. So we need to be able to clean in this concavity if there's a furcation involvement. Now, why is this important? I'm telling you this, especially now. Well, at the moment, when we're trying to minimize aerosol generating procedures or aerosol generating using ultrasonics, we're trying to focus our treatment on hand instrumentation. Now, this can be problematic because the width of a curette is usually larger than the width of a furcation entrance. So we need to look to either using narrow curette, something like a Mini 5, to be able to access and get into the furcation entrance. And I'll talk about the hand instrumentations a bit later. Enamel pearls, between 1% and 9%. I think personally from clinical experience, I feel it's probably closer to 1%. I don't see them that often, but you do see them sometimes. Often you have a projection of pulpal tissue going towards it. So be really careful in removal because you can get exposures in removing these enamel pearls. So you have to be very, very careful. Usually maxillary molar teeth. And yes, with enamel, you're not going to get connective tissue attachments. You'll get long junction epithelium, but that might be susceptible to loss of attachment in that area. And they're also a plaque retentive factor. And yeah, as I mentioned before, you've got to be very careful in removing them little bit by little bit, smoothing them. Okay, so cervical enamel projections, most common on mandibular molars, but also on maxillary molars. You will see, when you look for them in practice, you'll see them. And these are very, very common little projections here. And they extend onto the root surface. And again, they prohibit the connective tissue attachment. Now, there's various degrees on how far they extend. Now, if they extend all the way into the furcation, like a grade 3 cervical enamel projection, then it's at a higher risk of furcation involvement because you're not getting that attachment in the furca region. Okay. Going on to other nuances, other anatomical variants of furcations, we have bifurcation ridges. Bifurcation ridges are, it's like a ridge of cementum, just a mass blob of cementum, really. They are as convex excess of cementum running mesial and distal, and it's really, really common. What it means is it's just when you start to get attachment loss and bone loss, and you get the exposure of the bifurcation ridge, it becomes a plaque trap. So in its management, sometimes it's important to remove the ridge so the patient's able to clean. Various classifications of checking furcation involvements. Originally, the Glickman classification, where we have an extra fourth one where it's through and through and you can see it. So the wrist, there's attachment loss, there's recession, and you can see the furcation. That would be your grade 4. I'm going backwards, grade 3, you can go through and through, but it's not clinically visible. You have to probe it to check. Grade 2, it's furcal bone loss to varying degrees, but not all through and through. In grade 1, you've just got a soft tissue lesion extending to fluting, but there's no furcal bone loss, so you're getting a small amount of your neighbor's probe into the furcation region. HAMP HAMP and Lindsay is probably the classification which we are most familiar with. Grade 1, you're having a horizontal penetration less than 3 mil, 2 more than 3 mil but not through and through, and grade 3 through and through. It's changed to thirds, the Lindsay classification, which is essentially the same thing when you're checking if it's a through and through or not. Now, this is only classifying the horizontal component, but there's two components of furcation involvement. You have the horizontal and you have the vertical. And with vertical, Tano later classified these with A, B, and C. These are less familiar in terms of general practice. However, I think equally valid and something which is quite easy to add to your HAMP or Lindsay classification. So you have grade A for less than 1 to 3 millimeters, between 1 to 3 millimeters of horizontal bone loss, 4 to 6 of a grade B, and above 7 for a grade C. And you can combine these, as I mentioned. You could have, let's say, a grade 2 HAMP classification with a grade B Tano. And Papapanu wrote a great paper on combining these classifications. And it's quite informative to be able to do that. So how do we diagnose? We can use probing, we can use bone sounding, we've got periapicals, and we've got CBCT. So those are probably the most used and most influential ways we can assess the prognosis and assess furcation involved teeth. So probing is good, it's important to do. The problem with probing is probing in furcations, it can hurt the patient, and that can lead us to underestimating the furcation involvement. Now, what can be more accurate is when you are treating these with, let's say, non-surgical therapy. If you have the patient numb, you will be able to perform, without the patient feeling it, a bone sounding, feeling where the bone anatomy is, and get a much more accurate representation of the furcation lesion. So I'd recommend that first of all on your first assessment, to be able to probe and check with your curved neighbours probe the furcation involvement, but also to double check it when you're performing non-surgical therapy in the hygienic phase of treatment, so that you can actually assess it without patients feeling it. Radiographic signs, it's pretty inaccurate. When you can see it, it means it's really there, but often it won't show that the furcation is there, if that makes sense. So it usually shows it when it's too advanced. So ultimately, probing should be your guide, and when your patient's numb, bone sounding should be our guide. Yeah, so radiolucencies only appear once significant portion of the supporting bone has been lost, and they identify furcations more commonly in the maxilla of the mandibles. You can often see a furcation arrow. Depending on your screen, you may be able to see a little arrow here distal to the upper left first molar tooth here. Can predict furcation invasions only 70% of the time. And when the furcation invasions are truly present, an arrow is seen less than 40% of the time. So probing is more accurate. You mustn't rely on these. But if you see them, and it might make you double check your probing, that's useful information. But for radiographs, we're looking more at the bone levels to see if you can see a furcation arrow, but ultimately you need to rely on your probing. CBCT is pretty accurate. It's pretty good for assessing furcation involvements. I still think you have to use your bone sounding and clinical skills when the patient is numb, and I think that is the gold standard, and this is what it's compared to. However, if you're taking a CBCT, we need to evaluate the entirety of the volume, and while you're assessing other teeth, if you're looking at a tooth in front, you need to assess a tooth behind, you need to assess all the teeth in the volume, and it's important to assess if you can see furcation involvements, because it can quite accurately tell you if there is or not. The value of a CBCT would really be if you're unsure on the prognosis of a tooth, if you're questioning a fracture, if there is clinical doubt with all the other parameters. And a great guidance tool is Sodexis CT European guidelines for CBCT indications, and that's quite useful as extra reading to understand when you would take the CBCT. But really, it's just if there's clinical doubt with all the other information we have, then it can be very useful in giving us a prognosis of the tooth, and it can also plan if you're planning to replace with an implant. So we're checking assessment with a probe, we're checking with neighbour's probe. If it's a degree, if there's no probing furcation, we need to just maintain. If there's a grade 1, we need to treat with periodontal treatment. Grade 2 or 3, we'd need to take some radiographs, and there might be some complex treatment planning, might be surgical interventions, and you could also use a CBCT. Non-surgical debridement by hand. So if we're focusing on hand instruments in our practice initially, personally I like to use, there's a Micro Mini 5, which is very useful. It's very thin, and it's able to get in that furcation entrance, which is usually less than 1 millimeter. Other instruments are DeMarco furcation curettes, and you've got also Neighbour's diamond fast scaler. So there's lots of other tools which you can use if you're not using ultrasonics. If you are using ultrasonics, we have various different manufacturers of curved furcation tips, which are really vital. If you're using a straight tip, you're never going to be able to get into the fornix of the furcation, that dome shape I was talking about earlier, which is the most coronal aspect inside the furcation lesion. Open flap surgery as a treatment option is better access for instrumentation to be able to see what you're doing. Yes, ultrasonics are more effective than manual instruments in narrow furcations. So that is the indication for your ultrasonics. Rotary instruments can offer a benefit of removing deposits in narrow furcations, and also the bifurcation ridge. So you might need to do some dentinoplasty, or if it's actually bifurcation ridge, it's cementoplasty, because that is just an excess of cementum. So here's furcation plasty or osteoplasty. So furcation plasty is to smooth the actual tooth so that it's easier accessible to clean. And osteoplasty is to remove the unsupporting bone, to smooth the unsupporting bone here from this curvature to this architecture. So you are changing the architecture of the bone so the tissues can sit more favorably and the patient's able to clean the area better. So a removal of reduction of interradicular component of the defect. So we're removing the outside non-supporting surface, and that is what we call osteoplasty. And odontoplasty is reshaping of the tooth. Yeah, mostly applies to lower molars because it's quite tricky when you have three roots for the upper molars. And you must take care with tooth vitality and hypersensitivity. Tooth vitality, especially with enamel pearls, if you're doing any furcation plasty or odontoplasty. Tunneling is an option to create a grade 3 furcation. So grade 2s you can't clean very well, but if you're enabling a patient to be able to get the TP brush all the way through, like in the picture on the left, it can be very useful to do a tunneling procedure. What we know is the #1 cause of failure for tunneling procedures is caries. So it's important to use fluoride varnishes, have regular supportive periodontal therapy with a hygienist, and for application of varnishes, maybe a high strength fluoride toothpaste prescription as well, to prevent caries in the area. You want long roots and a short trunk. If you've got a long root trunk, patient's not going to be able to clean between them. So, and you want divergent roots when you're picking your case for tunneling. Yeah, so 4 in 7 teeth develop root caries at 5 years. So it's not periodontitis which kills a tunnel tooth. In more cases, it is caries. And what's important is that they need to be maintained. Can be done for upper molars as well. If the patient is very motivated and cleans very well, they can clean from the buccal aspect of both proximal furcations. And this surgery here is a pocket reduction surgery. We also combined a tunneling procedure on the 1/6 for the patient to be able to clean between the furcation involvement. A root resection, you have 2 types. You have a root amputation where you can leave the tooth in situ, or root hemisection, so removal of one root and you premolarize the tooth. For example, on the right hand side here, we've turned a molar tooth into a premolar tooth. So if there's vertical bone loss on one root of a multi-rooted tooth, which you can't treat by periodontal regeneration, so that includes root fractures. That's probably one of the biggest causes of why you take one root away. Or if just you have extensive bone loss, it's been root treated and there's a poor endodontic prognosis for that root, that might be another reason why you'd remove the root and not do a regenerative procedure. If you have, if you have close root proximity, so if your distal buccal root is very close to the mesial buccal root of the neighboring tooth, so you don't have a good blood supply for regeneration, that might be another reason why you'd remove one of the roots and do a root resection. Root fracture, which we talked about, and also, when root canal treatment cannot be possible, we've talked about that as well, and unrestorable caries as well. Contraindications, fused roots. To resect a root when it's fused is very tricky indeed. Bruxism, I'll talk about why it's not a good idea. Well, with bruxism, any occlusal trauma needs to be addressed because the #1 cause of failure of root resected teeth is root fractures. So that's something that you really need to take into account if you're deciding to root resect a tooth. Is the remaining root, if it's inadequate to serve as prosthetic abutment? So if, for example, the tooth is already mobile and you remove one of the roots, and then the remaining roots structures aren't strong enough to serve as a prosthetic abutment. So you need to take that into account as well. And oral hygiene is everything with any periodontal treatment. Suboptimal oral hygiene is a big contraindication for these procedures. So which route do you choose? If you are doing a root amputation, you choose the one with the least bony support. Hopefully it's a distobuccal root, because the distobuccal root has the smallest surfaced area when you compare it to the mesial-buccal root and the palatal root of an upper molar. So by removing the distobuccal root, for example, in this picture on the right-hand side, we're removing the root with the least bone support. The rest of the tooth is strong. There's no mobility, and we have no evidence of parafunction. There's no bruxism, and it's not the last standing tooth. If it's a last standing tooth, you have all the weight of the bite on that one tooth. Now we have a nice healthy 1.7 behind the 1.6 to support. So endodontic treatment, ideally before the amputation. It makes it easier. If you're able to put a core into the root, it makes it easier when you section the root. You have a nice restored surface and less stress, so you don't have to restore the side of the root while you're doing the surgery. And you have certainty that it can have a root canal treatment. The worst thing is if you had the root resection and then you root treated afterwards and realize the other roots aren't indicated for successful root canal treatment, then you've done an unnecessary procedure. If you were to resect a tooth which hasn't had root canal treatment, you generally have 2 weeks before the patient gets symptoms. So that is a little bit of information. However, I'd rather not do it that way. It's much better to have the root canal treatment first. Technique, we are removing distobuccal root. We're smoothing the surface here. It's a very small access cavity here, so we haven't chosen to crown the tooth. And this is a healing at 1 week on the right-hand side. Great access to clean. Now we have to check shim holds on the adjacent teeth and no shim stock holds on the tooth with the root resection. So treat the root resected tooth like you would an implant for the occlusion. You don't want shim holds when patients in maximum intercuspation, and you don't want any lateral forces on the tooth in excursions either. This is a root hemisection technique. What we're doing is we are doing a little crown lengthening at the same time by removing septal bone. So you remove the distal root, which is unrestorable, and we are making sure that we have removed bone in the septum so that the biologic width can be re-established and that a crown margin can go onto the mesial root. And can be provisionalized straight away. Okay. What we need to consider, if we are doing a flat parallel design, we need emergent profile that facilitates oral hygiene, a narrow occlusal table, shallow cusps. So we need to ensure that the occlusion on this tooth is light. And as I talked to you before, as I mentioned before, the most common reason for a failure is root fractures. So when talking about regeneration, 2 types of membranes. We have resorbable and non-resorbable. Resorbable are favored now. Non-resorbable, your PTFE type membranes, your Gore-Tex membranes are very good, but you have to have a second surgery to remove them. They are good for the larger types of GBR procedures for your horizontal augmentation when talking about implants, but less favorable now for regeneration around teeth for guided tissue regeneration. We tend to use a bone graft material as a scaffold and as a support structure for the collagen membrane. Also, biologic mediators can be used, for example, emdogain, which are enamel matrix proteins, amelogenin proteins taken from a pig's tooth bud that encourage chemotaxis of mesenchymal stem cells to the area to regrow the lost cementum and bone PDL. And also PDGF or PRP, PRF, lots of different autologous growth factors taken from patients' blood, and a combination of all of them. So these are all different modalities which are used to be able to treat furcation lesions. I think regeneration would be a whole other topic of lecture presentation, so I apologize if I'm skimming over it. It's just there's lots to cover when we're looking at furcations as a whole in an hour. As a general rule, to achieve furcation regeneration in a class 3 is, I don't ever like to say impossible, but let's say improbable, highly improbable. So it's not a treatment that I would be advising for a patient with a class 3 furcation involvement. We need to consider either a tunneling procedure, or if the prognosis is poor enough, a removal of the tooth. Class 2 maxillary furcations, less favorable. However, proximal furcations, so mesial and distal furcations in upper molars, can be treated successfully with emdogain. And I'll show you a case where I've done that later. Guided tissue regenerations tend to outperform just open flap procedures, so just open, clean and closing in class 2 maxillary and mandibular molars. So GTR does work and it's a good treatment modality. And we have better better outcomes when we combine the membrane and bone grafts together. So this diagram is from Bauer's study looking at regeneration of furcation lesions. He used allograft, so human freeze-dried bone. And this really sums up the capabilities of regeneration of furcation. We need to look at the crest of bone. In this case, we are only going to be able to regenerate, if this is the defect here, to the top of the defect. We are not going to be able to outgrow the bone crest. So this is our limit. And if we have CEJ to the bone crest, if it's large, if we've got a short furcation trunk, then we need to consider, should we be doing regeneration in this case, or should we be doing a tunneling procedure? Because we've got nice divergent roots, we're not going to be able to regenerate this area. So let's choose another treatment modality. And if we apply these considerations to, for example, this case, it hopefully will give us some treatment planning decisions. So here we have a lower right 7, 4-7, 10 millimeter probing depth distally, distobuccal and distolingually with suppuration. We have grade 2 buccal furcation involvement, intrabony component distally. And because the furcation involvement is shown on the radiograph, it is severe, okay? Now what we need to look for is we need to look at the size of the defect. It is a whopping defect, and I gave this patient no assertions that this would be the panacea to the problems of furcation. We had to be realistic, and I had to give this patient the realistic outcome, which it could fail, and that it's 50-50 whether it would work or not. However, it did have some things going for it. You had good bone levels. You didn't have, you had good bone levels mesially. So we had an area to support the membrane. We used a bone graft soaked in the patient's own blood. This is a xenograft, BioOs, cow-derived bone. And we used a collagen, porcine collagen membrane, in this case a BioGuide, to cover the defect. And after covering the defect, oh yes, I missed out. Root surface debridement, that's the most important thing. Then we used the xenograft and the collagen membrane. And we're able to have a great result with this treatment modality. Now, looking back on it, why did it work? Well, if we're looking at the Bowers diagram, we have good bone levels. We have good, the crest of bone height is good. We have up here and here, okay? So if we're able to support a membrane across here, I expect that we should get a good amount of regeneration of the defects. So here we're able to get a complete resolution of the pocket and the furcation involvement with this guided tissue regeneration approach. For the maxillary molar, a 9mm probing depth mesially, there is a medial proximal, so medial palatal furcation involvement grade 2. We did a thorough root surface debridement, conditioned the root surface with an EDTA gel, and used enamel matrix derivatives. So that's your emdogain, your amelogenin protein taken from the pig's tooth bud. What do we have going for it? We have this nice crest of bone here. So with this crest of bone, I know that we have a bony wall which can supply blood to the area and hopefully encourage regeneration. And we're able to get full resolution of this defect using the emdogain. So I don't know if you can see, I'll just show you radiographically, you have the bone level here. So this is the key to when you're seeing, will this work, will this not work? We need to look at the crestal bone level. What about alternative therapies? Now, some of you may laugh, but this is something which is quite common, and you do see it. It doesn't work. Putting a restorative material in the furcation area so that the patient, to stop plaque getting in there, doesn't work, because plaque will find a way under the restorative margin and will accelerate the bone loss. I have no idea how this group managed to get ethical approval for the study, but in a way it's good they've done the study, because now we can see that there is a negative correlation by putting a restorative material in the furcation area. So conclusions, when we look at survival rates of furcation involved teeth, we have, it's very varied. It's 43 to 91% survival, okay? Here for open flap or osseous surgery, so smoothing the bone. It's very varied because the indications are so varied. Same with root resections. Depending on the paper, if you look at Carnevale's paper on root resection, or even Paul Fugazotto from the States, they have 90% at 10 years, or 91, 90, 92, in the 90s. Reason for that is they are super strict inclusion criteria in which teeth they pick. They don't pick patients who brux. They pick patients who have favorable canine guidance. They have patients and they don't do second molar teeth. They make sure they have an intact second molar and there's a tooth either side of the resected tooth. They make sure it's a distobuccal root. All these things that are included in the strict inclusion criteria to improve the survival. So if we have a tooth which fulfills the inclusion criteria to reduce the risk of root fracture, a root resection is a great treatment option. It means you can keep your tooth for a lot longer, and you always have the option of an implant should it fracture in 10 years' time. Tunneling procedure, again, survival rate massively varied. Number one cause of failure is caries, so it's important with maintenance that you're continually showing the patient how to clean in the area and also applying your varnishes. And guided tissue regeneration has consistently high survival rates at a long period up to 12 years. So that is a great treatment modality we have to treat furcation lesions in the right instances, and provided that you've got the good bone levels supporting the defect for the blood supply. Just to finish up and then go through your questions, saving teeth is more economical than placing implants. This long-term study looked at the insurance policy in Sweden and found that less money was spent on saving teeth through these means of molars with furcation involvement than replacing them with dental implants and the associated costs with those. So it's important to know that implants are to replace missing teeth, not to replace teeth that could be saved. Furcations do create challenges. They create diagnostic and therapeutic challenges. You need to have good oral hygiene, good home care, and you need to be motivated to keep them. Case selection is everything in these cases, which I'll show you, especially the one on the right-hand side. And risk-benefit ratio and cost effectiveness is important to consider, especially before removing the tooth. And long-term documentation of tooth survival still exceeds that of implant survival. We have long-term data on teeth survival, which I showed you in the first slide from the classic studies, Hirschfeld and Wasserman and McFall papers, which we don't have as long follow-ups with the implants. Great. So thank you all for listening. I hope I didn't go through that too quickly. I felt I might have rabbited on a little bit, but hopefully now if there's any questions, I'll go happy to go through them. Thank you for coming along.
Hi there, Richard. Okay, can you hear me?
Yes, perfectly, thank you.
Great, thank you. So we just have one question at the moment from Canwell. What is bone sounding?
Hi, Pamela. So bone sounding is feeling the architecture of the bone with your probe. So you cannot do this without the patient being numb. They have to be very, very numb. So what you're doing is once they're numb, you probe the normal attachment to the junction epithelium and you probe through it to the bone. It will heal. After 5 to 7 days, you will get reestablishment of that junction epithelium. So don't worry, it will heal, but it's important, vital information that will tell you the anatomy of the bone. So here on this picture, you can see where the bone level is. Well, if you've got if you haven't raised the flap, you can feel it with the probe all the way down to bone, provided the patient is numb.
Okay, thank you, Richard. There's another one here from the Liverpool Dental Hospital. Is BioOS always your go-to xenograft material? What are your thoughts on its ability and duration for bone turnover?
Okay, is it my go-to material? Not for everything. For periodontal regeneration, yes. I have very little I stress very little importance on the actual material itself, rather than the fact that it's got to be a good scaffold for the membrane. With this treatment, if you're using guided tissue regeneration, for example, with here, the whole purpose of that xenograft is to support the membrane. The membrane is floppy. It's not stiff like the PTFE reinforced membranes. It's just to hold it there. So it doesn't have any osteogenic properties. It won't encourage bone formation. The membrane would do that. But what it will do is it will be a scaffold for the bone to grow on top of. So there are other xenografts out there. When you look at the research from University of Bern, from the schooling group, where most of the research on a lot of the research on furcation involvements and regeneration was done. These were the materials they used. So with that evidence backing, I tend to use those materials. That having been said, if you look at Bowers and a lot of groups in the States, they'll be using allograft materials, which had equally fantastic results. So allograft materials are also a valid alternative. Synthetic, we just don't have the amount of literature with synthetic grafts for furcation lesions.
Thank you, Richard. We also have another question from Camwell. I didn't exactly get what you meant by the term of tunnelling. Tunneling,
okay, fine. Can I draw? I think I can draw somewhere, can't I? Oh, where am I going to draw? I'm trying to find a blank page for me to draw on, sorry. No, I don't have a blank page yet. Oh, okay, fine. What I'll do here is I'll just annotate. Okay, fine. So let's see if I, oh, here we are, pink tooth. I have to apologize. This is drawing on a Mac trackpad. So it is, oh gosh, that is not a nice looking tooth. Well, it's not bad. Okay, fine, his tooth. Let's change the color. So we need to look at the bone levels. If we have a tooth here, and your bone level is here, so there's no endo lesion there, so I'm not drawing that very well. And you have furcation involvement grade 2, so this is your entrance to the furcation here, but then on the other side of the furcation, you have bone on the other side. So it's not a through and through, it's a grade 2 furcation when you probe in here. It's not amenable to regeneration because the bone height here, the crestal height, is lower than the furcation entrance. So we can't regenerate in here. It's very unpredictable. So what we can do for this patient is, because these roots are divergent enough, we can, and if the gingival margin is, for example, here, so the patient can clean it, we remove the bone on one side, so the patient's able to get a brush all the way through. Actually, I think before I'll clear that now. I'm going to go to, I have a picture of a tunneling above. Oh no. Okay, I've got it here. I'll just. So this is after a tunneling procedure, we're able now to get the brush all the way across. But before, there would be bone stopping the brush going through.
Perfect, thank you, Richard. Okay, we also have another question from Albert. Hello, Richard, great webinar.
Thank you.
Would you say using, I'm not quite sure if I've got this right, I think it says water pick water flosser or weight pick water flosser, is that more effective than the TP, or the mechanical cleaning is better?
So, evidence for, well, water pick, what you'll find is it will remove the top surface layer of the biofilm. What you won't remove is the acquired pellicle. You won't remove those glycoproteins that stick onto the tooth surface. For that, you need mechanical brushing. For patients who aren't able to clean between the furcations, for any patients with any manual dexterity problems or difficulties, then I think a water pick type or water jet type air flosser is a viable alternative, but it's not as ideal as using an incidental brush. The problem is they are really quite tricky things to clean, and patients do have to have a good level of manual dexterity to be able to clean between them, especially in the case I showed earlier here, where this patient is cleaning through an upper proximal furcation. And if the patient didn't show an incredible aptitude for reducing their plaque score to less than 5%, I don't think I'd choose that type of treatment for an upper molar. But for a lower molar, it's much easier.
Okay, thank you, Richard. So we have another question. They've not left the name, and they would like to know, do you always use membranes, and do you have concerns about infection?
No and yes. So do I always use membranes? No. So it depends on the type of defect. For proximal furcations for upper molars, I think I'm going to go through a lot of slides. I'll just go through here. I tend to prefer using Emdogain, just because there is good randomized control trials showing the effectiveness of Emdogain used at a mesial site here. And Emdogain means I don't need to raise the flap particularly wide. I just can open one papilla, and it could be a minimally invasive surgical procedure. With a larger defect, we have better evidence for using guided tissue regeneration. And for those cases, for these large defects, I tend to use a membrane. It's healing via exclusion with guided tissue regeneration. The membrane stops the soft tissue from growing into the defect, allowing enough time for the bone to grow onto the graft material. Am I worried about infection? With a non-resorbable membrane, yes. If you get an exposure of a non-resorbable membrane, it's not particularly pleasant. They will often get infected. They might have to be removed early, and there's much higher complication rates. With non-resorbable membranes, less so, especially also with non-cross-linked membranes. So there's loads of different types of resorbable membranes. BioGuide is certainly not the only one which is available. It's quite favorable in terms of low infection rates, post-operative complications. It might not stay there as long as you want it to, but it's quite safe membrane to use. I would also prescribe antibiotics when I'm using a graft in a membrane.
Okay, perfect. Thank you. One last question. Hi, great lecture. Any thoughts on the long-term survival rate of teeth with furcation defects solely maintained by non-surgical treatment?
So it depends on the extent of the lesion. So for your grade 1 furcations, these can be maintained very well with non-surgical therapy. When you get to a grade 2 furcation, it can't be maintained with non-surgical therapy alone, but it depends very much if the patient, if surgical treatment is indicated for the patient. So if they are a viable candidate for surgery, so if they have adequate oral hygiene, if they're medically well for the surgery and there's nothing contraindicating, then you have more effective ways of treating furcations by use of either root resection, tunneling, guided tissue regeneration, as I've discussed with you, which can improve the long-term prognosis of these teeth. Grade 3 furcation involvements, if they're able to manage it well and clean between them already with a TP brush going through and through, then non-surgical approach is also viable as well. So it's usually the grade 2s which are the sticking point, which you need to look at other treatment modalities.
Okay, perfect, Richard. So that's the end of all the questions. So thank you very much. That was great. So I hope you enjoyed that, Richard, as well.
Thank you. No, thank you for having me. It was great to be here and to give a talk to Tips and Training. And yeah, thank you. I hope you enjoyed it.
Yeah, so have a great day, and thank you everyone for joining us today. Thank you.
Thanks.
Take care.